Yeah.
No one knows.
All right, so we'll get going. Um, so I'm happy today to start off grand rounds for a new year, 2026. Everyone I talk to seems to be wanting to go into 2026 very optimistically and thinking it's going to be a great year and better than 2025. So I'm not sure if it's a comment on how they feel about 2025 or that 26 should be a good year. But welcome to the new year and the new year of pediatric grand rounds. So Ottawa is built on the unceded Algonquin Anishinaabe territory, and the peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Um, Today we have Dave Dyment speaking. So Dave has been a clinician in the Department of Genetics at CHEO for the last 14 years, coming up to 15. And I was just chatting with him about, is it already flown? So time seems to have flown. Prior to this, he completed his residency in medical training at the University of Calgary. He obtained a Doctor of Philosophy from the University of Oxford in Human Genetics and an MSc from UBC in Medical Genetics. He's a full professor in the Department of Pediatrics and a scientist at the CHEO. The focus of his research and clinical endeavors has been on the study of rare epilepsies and encephalopathies, in addition to recognizable malformation syndromes. It also doesn't say in his biopsy, he's incredibly humble for all the work that he's done and the high quality of that work. So it's really a pleasure to have him speak today. So the title of his presentation is Genetic Testing for Individuals with Epilepsy in Ontario.
Thank you, Crash. Okay. I'm going to put my coffee down, and I hope I don't spill it. Yay. So thanks, everyone, for coming to these first rounds. And I was actually just mentioning that this is the first time I've given rounds in any setting since COVID. So, I don't know, maybe I've got a few butterflies. Anyway, I'm going to be talking about epilepsy genetics in Ontario. And I do stress that I'm a geneticist. I'm not a neurologist or pediatric neurologist. And I always like to make that note. And I'm also part of the biology breakthrough team at the CHEO. Okay, here we go. If it'll move. Nope. Yeah, I'm sure it's just something I haven't.
Your screen. Try tapping on the screen.
There we go. So the learning objectives are pretty straightforward. Hopefully by the end of this talk, you'll know the benefits of a genetic diagnosis in epilepsy, understand any next steps that can be taken after receiving genetic test results, and also appreciate the benefits of a more programmatic approach to genetic testing that we have in Ontario. And is unique to Ontario. Okay, so in terms of the actual talk today, we'll talk a little bit about the genetics of epilepsy in very broad themes. Also, we'll touch on next generation sequencing, and that's a big topic, but we'll touch on that as it relates to epilepsy, and then the implementation of testing for epilepsy in Ontario. I'll also touch on ECHO, which is a tremendous resource that we have, and then a summary and future considerations. Okay, so this picture kind of sums up epilepsy genetics. These are three young people. They all developed epilepsy at the same time. They're sisters, of course, they're triplets, and they share 100% of their genetic material. The kind of epilepsy, their type of epilepsy is the same. They have generalized, well, they have similar EEGs, and they're also responsive to the same medication. So that just tells you, you can't not, it screams genetics if you were to ever see this in your clinic. And quite often we do see people with multiple family members with epilepsy. This is the figure I often use in my talks, and I like it a lot because it captures this big blue, light blue, purpley, blue section where it stresses genetics, And people have estimated that maybe genetics is responsible for anywhere from 60 to 75% of individuals who have epilepsy. Now, of course, the other more colorful section is, I'm not going to go through each one, but that's things like trauma, infection, tumor, autoantibodies, and even this other blue section called focal epilepsy with MRI detectable lesions. Now, I'm not going to talk about that, but that might be something for a future talk, because what people are doing now is they're actually sequencing these lesions and finding mutations. And these are mutations that you wouldn't detect in an individual with epilepsy from a blood draw. Anyway, I'm going to focus on the big blue section, and the first area I touch on is the modifiers and susceptibility alleles. And this is an area where I think a lot of people with epilepsy, that's where the genetic contribution is. Also, there could be individuals who have epilepsies with more of a complex inheritance, and then the single gene epilepsies. And we'll talk about each of those. Okay, so how do we study these individuals who have epilepsy for susceptibility contribution? And that's with family studies. And that was really sort of sorted out in the 1800s and early 1900s. And basically, let me go right to the next one. Yeah. So it's simple. You look at individuals who have epilepsy and you look at their relatives. And if you have, say, a childhood absence epilepsy, and your brother or sister wants to know what their risk is of having juvenile absence, it's about 5 to 10%. If you have a child, what's the risk? It's about 7%. And this is going to be higher than the general population and in keeping with a genetic contribution. How we study that traditionally is with the use of twin studies. And if you look at identical twins and compare them to fraternal twins, you can look at the concordance rate. So, for example, an identical twin are monozygotic with 100%, they're twins who share 100% of their DNA. The concordance rate of epilepsy is about 28%. If you look at dizygotic twins or fraternal twins, the concordance rate is only 7%, similar to that the first degree relative rate that we saw in the previous slide. That is in keeping with a more multifactorial mode. It's also in keeping with recessive mode, I know, but if you look at other relatives, it's all in keeping with something that's a bit more multifactorial. And that means that there's lots of liability genes, lots of liability polymorphisms and susceptibility alleles. And if you have a family with more of these, you're more likely going to have seizures. There's no genetic test for this today. Maybe down the road, people will work on this and figure out a test where you can devise your susceptibility risk. I actually wanted to study this when I first came here, but I don't see these patients. I have no idea how to do the computational genetics that would be required, and I thankfully did not pursue this, because I would have 0 papers by this point. Anyway. Okay, so now let's go to the more genetic epilepsies with a complex inheritance. And how you can tell I'm very much when I look at genetics, I'm often thinking of it with the technology that's associated with it. And if you are looking at these epilepsies due to a complex inheritance, you might get that information by the use of a microarray. And so a microarray was an advancement that we had when I was a resident. And basically, you're looking throughout the genome for any deletions and duplications. And it's normal to have deletions and duplications throughout your genome. However, some of these can be associated with neurodevelopmental disorders. So, for example, you may have, there may be some of these deletions and duplications associated with autism, with schizophrenia, with learning disabilities or ID, and of course, epilepsy. So one of the key microdeletions in the genome is on chromosome 15 on the long arm. And if you have epilepsy and you have one of these deletions, I'm going to say to you, this is most likely the main reason why you have your epilepsy. The odds ratio is about 68 for epilepsy. So I do like to highlight, though, that these deletions are rare. 19 times out of 1,762 individuals with epilepsy. And you can see them in control. So these are people without epilepsy. So 8 times, granted the denominator is 50,000. But when you test parents, you oftentimes find a parent who carries one of these deletions, and it puts it into context because these parents may not have had epilepsy. Some other copy number variants that we can see in the clinic. Usually it's chromosome 15 and 16. So we have, what do we have here? We've got 15q11, 16p11, 16p13, as well as chromosome 1q21 and 22q11. How useful is this information? Maybe not that useful, if I'm being honest. It's certainly, if you were to start testing family members, you would see that it probably doesn't segregate with, oops, I don't know what that is. I like it though. Anyway, so I think maybe that family 2 is a good example where the proband has juvenile myoclonic epilepsy, and so they test the parents, and the father, who also has juvenile myoclonic epilepsy, does not carry the copy number variant. And then and then I like this example in family 3, where the mother is the proband. She has juvenile myoclonic epilepsy. Her affected son does not carry it, but her unaffected son does carry it. And again, speaks to just the complex nature. There's probably other genes and other factors involved with how someone will present. It also touches on ascertainment bias. This is the last comment on microarrays, but this is a good study where the researchers looked at 805 individuals with epilepsy and with a chromosomal microarray. They could get an answer in 40 of the 805, so about 5%. That's actually pretty good for genetics, but maybe not for anything else. Just to put it in context, autism is sometimes we say 10 to 15% for detecting a microarray copy number variant in autism. So it's in the same ballpark, but maybe on the sidelines a bit. Of those 40, really you could look at 28 of them and say, these kids actually have a recognizable syndrome, something that you might see in that Smith's malformation syndrome book. The other 1.5 or 12 of the 805 people looked at had it due to one of those copy number variants in those hot spots on 15 and 16. Okay. So that certainly was a very exciting time when we had that technology, but it wasn't really necessarily that helpful for the family when you're doing your counseling in the clinic. What I was most interested in, and lots of other people, were in the single gene causes of epilepsy. And this could be due to a new mutation in a person. It could be due to an inherited dominant variant, or it could be something that's recessive. And when I first came to CHEO, I came from Alberta, and I was so excited because I could finally order these gene tests. We couldn't order them in Alberta at that time. Hopefully there's no one... Anyway. They might disagree, but it's true. I know. Yeah. So I got a chance to start ordering these genes, and what we did was Sanger sequencing. And Sanger sequencing is something you may remembered from your high school days. And really, there was about 20 genes at that time that were available in the commercial companies. And there was this great paper, I really liked it. It was by Dr. Ottman, where they were looking at these 20 genes and said, well, what's useful here? What should we be testing? And they decided that really genes where if you knew a result that was positive, or negative, if it could predict the outcome, if it could halt further invasive testing, if there were some implications for counseling for the rest of the family or prenatal options, and certainly if it could alter management, they felt that those were deemed useful. And there's certainly a subjective nature to what they were doing, but they did look at those 20 genes and they did identify some that were very useful. I'm not going to go through all of them, but I think maybe perhaps SCN1A, which is one of the more common epilepsy genes. If you had someone with a clinical diagnosis of Dravet syndrome and you sequenced just that SCN1A gene, you might get an answer in 70 to 80%. And an answer being a positive mutation or a mutation. And because that would help guide management, it was deemed very useful. The same for childhood absence, or maybe a typical childhood absence seizures. If you sequenced for SLC2A1, your diagnostic rate is a little lower at 10%, but it was still deemed useful because you can put a child on a ketogenic diet, and that could have some implications for their long-term outcome in a positive way. However, these tests were all very expensive. They ranged anywhere from $1,500 for a single gene to up to $12,000 for a panel. And I remember often asking the ministry for funding, and they oftentimes said no. And every once in a while, I'd make my case, and I didn't get that many positive results. Now, I didn't really add all those up because every gene panel is different, and it was quite a complex path. These panels were labor intensive to do, and there's long turnaround times to get these results. All right. Thankfully, the field of epilepsy genetics was transformed. You may have seen this slide before if you've seen a talk by Dr. Jody Warman. I like it, but the whole field has been upended in a positive way because now we can do these tests in a more comprehensive way, in a timely way, with using something called next generation sequencing. This might be the time you can get another cup of coffee or look to see if the dog needs to go outside. Anyway, there goes Alex. He's getting his coffee. I'm going to have one slide where I'm going to just describe next generation sequencing in a very broad way. And so I'll just start. You get your DNA. You shear it into a bunch of fragments. You take those fragments and you add adapter sequences to the ends. You then anchor those fragments, these random array of fragments from throughout the genome, onto some kind of surface. It could be a bead, it could be some form of array. Once it's anchored, you then amplify each of those little strands of DNA. And each of those strands might be about 150 base pairs in length, or thereabouts. You start to amplify and you have these little colonies. You can then, in the base pair by base pair manner, start adding nucleotides that have a fluorescent tag to these colonies. And every time you add it, you then fluoresce the tag, and then you take a picture. And so at picture 1, you're going to have, say, here you got blue, orange, red, green. And that's going to correspond to a specific nucleotide and a specific colony. You then wash that away, and then you add the next nucleotide that has a fluorescent tag. And you take another picture, and then you do it again and again and again and again, and you're going to have a nice string of nucleotides, and then you know that that there's 150 base pairs, and this is what the sequence is. You then have to map that back to the human genome, and this can only be possible due to the Human Genome Project. And very powerful technique, and it allows us to map back all these sequences, and we get basically a full contig of the human genome. So, some terms to know. One is the genome, and that's the complete complement of genetic information. There's the exome, that's the protein coding sequence of the genome, and that's about 2 to 3% of the genome. And that's very important because that's where a lot of the mutations live. You can use a multi-gene panel, and that's where you just amplify the genes that are associated with epilepsy. And that's something that we're going to talk a lot about coming up. What are those red things? How do you... It's okay. All right. And
Dave,
then we
someone
have...
annotated your slides.
Oh, nice. Oh, did I do
Yeah.
it?
No, you can do it. I saw it's Magda. Sorry. I saw someone drawing on them by accident, I'm sure. That's what it is.
Thank you. I wish I learned... I don't know how to draw on my slides. Okay, so I'm also going to touch on something called an exome backbone. So that's when you do an exome, where you have all the protein coding sequence available to you, but you only analyze the genes associated with epilepsy. And that's doing a multi-gene panel on an exome backbone. Okay, now I can't talk about the application of next generation sequencing and disease gene discovery without talking about CHEO and Care for Rare, and before that, Forge. And this was an incredibly successful project headed by Dr. Kim Boycott. And I was going to make some comment that she's my boss. That's why I'm making sure I'm talking about this. But yeah, yeah. Is she here? Oh, anyway, this was a project that really involved the entire country, and everyone across the country provided families to have this next generation sequencing performed. And that's not the slide I wanted. This is the slide I wanted. And basically, this is a slide made by Tyler Hartley, I believe. And it shows just some of the genes that were identified by Care for Rare and sort of where they are where they're expressed in the cell. And these are 99 genes, and I put little asterisks by all the ones that are involved with that have seizures or epilepsy as part of it. And it's about 46, or almost half, of these new disease gene discoveries had epilepsy as part of their phenotype. So just showing you how important that this phenotype is. By knowing the gene and the protein that is made from that gene, you can get a sense of just where how you can get epilepsy. Up to this point, I think a lot of us really focused on the ion channel and the propagation of the action potential along the neuron. However, once we saw all these genes and figured out what they did, it did give us a little bit more of a sense of what can also cause epilepsy. So interneuron migration was noted, neurite formation. I'm just this is a list I made here. Cell-cell adhesion for a gene called PCDH19, apoptosis and DNA repair. We found a gene here that was involved with the recycling of neurotransmitters into these vesicles. And of course, the binding of those neurotransmitters is also very important. So all that really provided some insights into epilepsy biology. This was not one of the novel gene discoveries. When we identified this in one of the families at CHEO, it was basically the second report of mutations in a gene called ASAH1. And I'm just bringing this up because not only do you get insight into the gene and the protein, but you can also take it further and try to come up with new ways to treat your patients, or just even get some more insights. So for this particular individual, we found that the child was deficient in acid ceramidase because of these mutations. And this resulted in an increase in ceramide in the central nervous system. And we didn't actually look at her central nervous system, but we looked at her skin cells, and we saw this increased ceramide. And we found ways that we could actually bring down the ceramide. We've now gone on, and we've actually made a mouse model with these exact same mutations. And these mice also show epilepsy or seizures. And I'm doing a lot of that work with the Dr. Steph Bennett. So this is ongoing. It takes a long time to do this type of work, but I think it's all that next generation sequencing was that starting point for this work. Okay, well, enough with the research. How about actually applying this to families? Oh, did I miss something here? Oh, let me go back 1 second. There. I always talk. This is just showing the incredible increase in epilepsy genes that were identified once we had next generation sequencing. And, it's really, when I started here at CHEO is when it all began. And a lot of this was done by by people in Australia and, of course, the United States, and with Care for Rare. So I think that's maybe all I'll say for that one. Okay, so we started using next generation sequencing to the children who were recruited to Care for Rare, and we found that we were able to diagnose a lot of these individuals and provide information for the families. So there's the smallest one there with nine families. That's the one that we did, and we found a diagnosis in 7 of the 9 families that we applied this to. Now, these were very selected families. They're enriched for syndromes, but it still highlighted the importance of sequencing. Okay, and next generation sequences does meet several challenges. So if a disease is really considered too rare, like there's no way a clinician is going to be able to say, aha, this presentation is classic for, actually, maybe some people here might. I'm just going to make up a gene. Let's say, here's one, IQSEC2. I certainly couldn't do it, but if you do have a broad panel, you might be able to capture that. And that's the same for if there's hundreds of genes, you want something that's broad. It can also capture those individuals who have atypical presentations, and if you do an exome or a genome, you can identify novel epilepsy genes, and it's much quicker and it's less expensive. There are certainly benefits to getting that result. It'll inform the long-term prognosis. It might give you some insights into a surveillance plan for that child. It can halt further invasive tests, such as a muscle biopsy. It can reduce further specialist consultations trying to come up with an explanation for the child, limit the time admitted to the hospital, and inform counseling and testing for at-risk family members. And it can certainly provide prenatal testing options. This last one here is probably the one I should lead with, the psychosocial benefits for the family, because everybody I meet, they're like, thank you, finally, we have an answer. And even though there's maybe nothing we can do because the child's being well managed with regards to the epilepsy, they can get rid of some of the guilt, and it also allows them to kind of reach out to other people throughout the country and the world, usually through social media, and make connections and share their experiences. Okay, so, and this is a bit more the direct implications for a diagnosis, and I spoke already of the SLC2A1, so that's a mutation where if you have a mutation there, you can have a GLUT1 deficiency, and if you have that, you can have a ketogenic diet, and that can have very positive impact on seizure frequency, as well as your long-term development. Probably one of the most common genes that we see mutated in Ontario is PRRT2. And if you know that that's the gene, well, carbamazepine is very effective for many of these individuals. This one is extremely rare. Mutations in FOLR1, or folate receptor deficiency. And we came across a family where this was the diagnosis in their adult children. So basically it was 2 sisters. Around age 2 to 3, they started to have a regression, and they required a wheelchair by age 7. They lost the ability to speak, and they started having these seizures that just continued daily. And if you look at their MRI, there's certainly extensive white matter damage, and it just seemed to be a slow, progressive decline for these 2 sisters. And they were getting to the other sisters, the unaffected sisters, were getting to an age where they wanted to have children of their own and wanted to know the risk. We did next-gen sequencing as part of Care for Rare. Now, of course, that diagram there is a Sanger sequencing plot, but it just shows that there was a mutation identified in the FOLR1 gene, and it confirmed a diagnosis of cerebral folate transport deficiency. So now this was in Alberta, and the doctors there arranged for folinic acid supplementation for these sisters. Now, if they had started this at the very beginning, this would have definitely helped significantly. Can't quite say how much it would have helped, but it would have helped. But they were able to start it for these sisters, and after a bit of time had passed, they did notice that there was a reduction in the seizure frequency by half. I then followed up about a year or two later, and physiotherapy and the family had commented that the tone of the children had improved, and they had also started to regain some of the words that they had lost.
So if this was a newborn screen, you think that it would have an even better outcome, Dave?
Better outcome than that. I'm not sure how good an outcome it ultimately would have had, but yeah. Negative testing also has some benefits. Maybe I'll just use the SCN1A as an example. If you have a child who you suspect has Dravet syndrome and you test SCN1A and it's negative, well, then you maybe consider other anti-epileptic medications such as lamotrigine or phenytoin, some sodium channel agents if it's not SCN1A. Okay, so when all of this is happening, all of us started doing the tests. We all got very excited. And we started doing these multi-gene panel tests, and we'd send them out of the country. And it was a bit of a Wild West. And we decided to take a look at how good all that testing was. And this was done by Dr. Leduc Pissa in pediatric neurology. And she was able to find 227 of these tests that had been performed at CHEO and sent out of country. And she noted that this test provided a molecular diagnosis in 19%. She also noted that 77% of these tests had something called a variant of unknown significance. So this is when you have a change, but we don't understand if it's a benign change or a more pathogenic change. Half of these diagnoses could be explained by 4 genes: the PRRT2, PCDH19, KCNQ2, and SCN1A. And the vast majority, we're a pediatric hospital, but the vast majority had their onset before age 1, and no one had an onset after age 5. Okay, so just tells you how helpful that is. 19% again is high for genetics. That would be a game changer for us. So at that time, it was a bit of everyone started ordering this test. And if you can imagine, if this test is about $1,000 or thereabouts, this is going to have an impact on our provincial budgets, really. Not that I'm privy to the details of that, but this was something that we published, and that, in 2012, 2013, before the testing really took off, there was about 60 of these out-of-province tests that were performed. But by 2013, 2014, it had jumped to over 300. So there's a 4 to 5-fold increase in out-of-province testing just for epilepsy alone. There were few restrictions as to who could request these tests. There was no criteria for the epilepsy testing. There was an increased number of commercial companies that were offering the panels, and they were offering more and more genes on those panels, with usually the bigger is better type of marketing. There was a lack of information regarding the individual test performance, and the ministry was looking for guidance. So at that time, there was something called the Genetic Testing Advisory Committee, and they set up a subgroup to look at epilepsy. And this subgroup consisted of neurologists, metabolic specialists, and medical geneticists. And there were 8 members, and they basically provided their expert opinion as to what the clinical criteria should be for genetic testing in Ontario. And this was largely led by Dr. Carter Sneed in Toronto. Okay, so some of the questions that the committee wanted to address was which patients should we be offering this test to? Is there a minimum number of genes that we should be doing? Or should we just go as broad as possible? Is there a preferred panel at maybe GeneDx or prevention genetics? And should the province decide, or should it be something the clinician should decide? Who should be doing the ordering and interpreting? How does the test directly and indirectly affect management? And lastly, how do we make this process efficient so you don't have to wait weeks to get the ministry approval, and accessible so as many people getting the test as possible when it's appropriate? All right, so they came up with, yeah, please. Oh, hey, Sean.
Yeah, ministry making you decision.
Yeah, that's a good.
Can you repeat the question?
Yeah, thank you. So Dr. Bogue was asking who makes the decision, and basically it's the Ministry of Long-Term Health. I always get it wrong. MOHLTC. And so it's experts on that group. We don't know who they are, but they do know genetics, and they make that call. If that test has been performed in the past for the same indication, it's typically a check mark. You get that test. But if it's a new test or an indication that they don't have much experience with, it may take quite some time before you get approval, or it's declined. Okay, excellent. So I think who gets tested, certainly when the clinical features are consistent with a distinct electroclinical syndrome, when the prognosis is considered poor, and when epileptic seizures are refractory to treatment, and also when epilepsy was associated with an inborn error of metabolism, or suggestive of an inborn error of metabolism, when you could see differences on the MRI, and when there could be some evidence of neurodegeneration, and any time when you were suggestive of a developmental delay or intellectual disability, those individuals should certainly get testing. Things have changed a little bit since this time, and a lot of these people would actually have more comprehensive testing today. Okay, so the steps to testing in Ontario, it really did start with this GTAC subcommittee on and developing this checklist for who gets tested. The Ministry of Health then wanted to bring back all this testing to Ontario. We were sending our money out of the province, and we were developing expertise out of the province. And so the thinking was that let's bring it back to Ontario and come up with a good test that was consistent and maybe hopefully accessible to as many people as we can make it. And then we've done that, and then we've also wanted to see, well, how is that epilepsy program faring? And we've published that data as well. So when we wanted to bring that data, we wanted to make sure we highlighted accessibility. And we also have in Ontario something called ECHO, and I'm going to talk about ECHO, which is a program to provide more education in the province for epilepsy testing. The recommendation 2 from the implementation subgroup was to provide a high quality test. We didn't want to have genes on our test that weren't really associated with epilepsy, which is what we were getting when we were sending out to places outside of Canada. And lastly, we wanted a system in place where there'd be continued improvement of the test. All right, so, and I always have to make sure I have my notes out for this one. Project ECHO came about around this time, and this is currently headed by was always headed by Dr. Lisa Lomax in Kingston, and also now co-led by Dr. Kevin Jones at McMaster. And we also have an ECHO hub, and this is other part of the group, headed by Dr. Vanda McNiven, a geneticist, and Dr. Ahmed Abushama, a neurologist, and a genetic counselor, Dr. Stacy Hewson. And really, ECHO it stands for, I always have to, Extensions for Community Healthcare Outcomes. And this is using telemedicine, but not as a e-consult type of telemedicine. So it's not the traditional telemedicine where you have someone in Toronto guiding the management of someone in Timmins. It's really an ECHO team, a team a hub that meets with the physicians in the community, and they provide cases, and we discuss the cases as a team, and then those now primary care teams in the community can then test their patients. And it's sort of an all teach, all learn type of model. And we've had probably about 10 or 12 sessions of these of Project Echo for epilepsy genetics. Each session is takes 7 weeks, and the first and it consists of a 10-minute didactic teaching with 50 minutes discussing patients from the community. And usually we have participants, like 10 to 30 participants. And I took part of this a few years back. I'm not doing it now. But, we review clinical criteria for genetic testing with the physicians in the community. We talk about the requisition process, the nuts and bolts of doing it, what we want to do for genetic counseling in terms of pre and post-test, as well as which panel should be selected. And then should this test also, instead of being a panel, should it be an exome or a genome? And we have some, a lot of RNs take part, as well as MD specialists. But and we do have some family doctors also participating. And of course, I think it would be nice if that increased. So that is trying to get more people access to the test. The other thing is the test itself. We wanted it to be of high quality, and we decided to use the principles set out by something called ClinGen. And this is an NIH-funded resource where they come up with authoritative designations of how clinically relevant an epilepsy gene is. And there was an expert panel where they kind of go through 150 genes and say, is this gene involved with epilepsy or not? And they have a standard matrix that is applied to each gene, and this is about half the matrix. And you have to score a certain number of points. And if you score over 12 points, you're going to have definitive evidence. You can have, and then as you go down, you can have strong evidence, and then moderate and limited. And we really wanted to make the tests done in Ontario to be definitive and strong disease genes as it relates to epilepsy. We did include a few moderate genes, and those people who proposed those genes had to make a case for those. So here we go. We now have the Ontario Epilepsy Genetic Testing Program that started in 2020. And it consists now of 167 genes, all of, I'm going to say, good quality genes. And I'm going to speed up a little bit. I notice our time is getting away from me. If you look at the last page of the requisition form, you can see that the lab wants to know who's ordering the test. So if you're a physician in Ontario, you check the box. But if you don't have to be a pediatric neurologist, you don't have to be a geneticist. You can be someone who's taken that echo epilepsy course, and then you can do the test. We also included this management impact form so that we can get a sense of what this gene test was doing for the patient. And typical results included a completely negative or normal result where we didn't see any variance. We could see a variant of unknown significance, and I mentioned how common that is. Or we could see something that was clearly pathogenic or likely pathogenic. When you get those results back, let's say you start with a pathogenic variant, you do have to ask the question, does it make sense? If it does make sense and you're comfortable sharing that information with the family, you talk about it and you come up with a plan. If not, you can always send to genetics or send to genetics for at-risk family member testing. If there's a whole bunch of variants of unknown significance that you don't know what to make of, oftentimes people will send to genetics so that we can arrange parental testing, and that can help clarify the significance of those variants. Sometimes a negative test can be sent to us as well because you just don't believe it. You're convinced there's something genetic here, and maybe there's another test that we can do. So here's some examples. This is someone who came to me, and it was a healthy 10-year-old boy. They had epilepsy at age 6, but at 10, EEG was normal, but they had these two POL-G variants. Now, if you know anything about POL-G related disorder, it's a recessive condition, and it's a very serious multi-system disorder, and children can pass away from it. So these parents were, as you can imagine, extremely upset. They were very concerned that their child had this condition, but it didn't make sense. A healthy 10-year-old boy, well controlled in epilepsy, that doesn't fit. And furthermore, when you test parents, you see that mom had the same two variants. That tells me that they're on the same chromosome and that this child had another healthy POL-G gene from father, and that the child was just a carrier only. So that's very reassuring for the family. I didn't have any significant testing to do other than a microarray. And I told them to come back and see me in 5 to 10 years. All right. Example 2, this would be another classic presentation for coming to genetics. It's a child with seizures and some mild ID who had one of these panels done, and they had all these variants of unknown significance. And, you don't know what to... I look at this and I kind of sigh. However, one of the genes caught my eye, and it's called TRPM3. And it was actually one of these moderate evidence genes. And this was actually a gene identified by one of our colleagues in the past, Dr. Matt Lyons. And it's an epilepsy, or individuals with mutations in this gene can have epilepsy about half the time. And sure enough, when you test parents, you found that neither parent had this. It was de novo, and there were some research things that went on after that, but the family was able to reach out to other family groups, and there's the consideration of a drug called primidone, which is already used for seizures, so that has been shown to be an effective treatment in these individuals. And some people have even said that primidone can help the cognitive function. I'm not so sure if the evidence really supports that, but it is helpful for the seizures. And lastly, an example where someone with progressive myoclonic epilepsy came to the clinic. They also had schizophrenia, and it made history taking difficult. So it was hard to get that background information. However, we did do this test, and it came back normal, or no variant seen. However, if you know progressive myoclonic epilepsy, you know that sometimes it can be caused by an expansion mutation. And so this one did have to be sent out to the United States, and we were able to find expansion mutations in the CSTB gene, which was responsible for progressive myoclonic epilepsy. So the Ontario test, the Ontario test for people who are positive, that would be I think that's green, yes. No, sorry, not green, it's orange. And basically, 17% of people are getting positive diagnoses. The purple is the negative or normal test results, and then the green are the variants of unknown significance. So the people who have the highest diagnostic rate are really the early infantile epileptic encephalopathies. The lowest are actually the actionable panel. Now, I didn't mention the actionable panel, but that's a panel where you get the results back within 2 weeks, and it's felt that there are some actions that can be taken that can impact outcome. All right. So, 5 minutes. Okay, you got it. 7 max? Excellent. Okay, we should be able to do it. Should be able to do it. I timed it 45 minutes, which was 5 minutes ago. So I'm obviously going slow because I'm doing things like this. Okay. 25% of the time there was an impact on management. That would include referrals to specialists, referrals to surgery, and also, of course, the neurologists being able to modify the medications that were being given to the individuals. All right, so the OEGTP, I think, is a very unique test that we have here in Ontario. We have a steering committee that's continually reviewing that panel content. That steering committee is made up from people not just from sick kids, but from all around Ontario. And we're also continuing to use those ClinGen principles, so making sure it's a high-quality test. We're continuing to work with Echo Epilepsy to make sure that as many people can have access to this test. And we also facilitate new technology. So 1 minute each for these new technologies. And it's more like a strategy. So for an example, one person suggested, hey, could we do a reanalysis of our epilepsy testing after a year or two has passed? Would this help improve the number of diagnoses? And sure enough, we took 87 unsolved individuals. We did a reanalysis, and we found that we could get a diagnosis in about 15% of individuals with epilepsy. Now, these are individuals with epilepsy and intellectual disability, because those are the individuals who got the exome test. And so they actually had a multi-gene panel, but on an exome backbone. Okay. All right. Now, anyway, so this I think is very important, and I think it does lead to the fact that we should be incorporating reanalysis as part of our routine follow-up. Another area that is something that we're doing, it's with people in London, Ontario, and that's looking at methylation. And that, if you can imagine, all the genes in your genome are packaged, and they're all covered. They have to have lots of proteins to help with that packaging. Whenever they're expressed, they have to become unpackaged and the gene expressed. So if you have an insult somewhere in that genome, it can have these downstream consequences where many genes are turned on and off that are different than elsewhere. And you can get a signature. And if you look at some of these epi-signatures, they become highly specific. So here's an example of someone with a Cornelia de Lange signature, and if you have that signature, you got Cornelia de Lange. But importantly, all those other signatures are negative. So if you got a variant of unknown significance in one of those signatures, you can rule out that variant of unknown significance. So it's very helpful. And I'm just going to say very quickly that we have started looking at these signatures in epilepsy. In the preliminary studies, we were able to see one episignature in someone who didn't have a diagnosis. It was for a type of dystonia that also has epilepsy. And that person went on to have sequencing and showed that that was indeed the diagnosis. So I'm not going to talk about Genome Sequencing Ontario. This is another great resource we have, but this is when you sequence every gene. Maybe it will be everyone soon. But we do recently have some changes in the indications for getting access to GSO. And so if you have epilepsy, but you also have autism or mild ID, you can get access to Genome Sequencing Ontario. And we'll see, I think, in the future, what the diagnostic rate for that in epilepsy would be. So the future, we're going to continue to update those genes. We're going to hopefully place those multi-gene panels on an exome backbone, though that's not really my call. We're going to hopefully incorporate reanalysis as part of routine care and facilitate research. And so in conclusion, epilepsy genetics is complex. Oh, and that's it. Oh no, I thought that was my... Gotta stop. All right. And just really unique resources with the OHETP, with Echo Epilepsy, with everyone doing great research in a province, and access to GSO. And lots of people to acknowledge, but certainly Alex McKenzie's here. Oh no, he's gone. I don't have to acknowledge him. Anyway, everyone on this slide, but in particular, Dr. Kim Boycott. So thank you very much. So, I got a question from Dr. McMillan.
As a pediatric neurologist, the biggest group that we worry about, the highest priority, are the children and often infants who have a treatable epilepsy. Can I ask you, how are we doing at getting a timely diagnosis for those children? Because the longer we wait, the greater the risk of irreversible harm.
Yeah.
And is there any consideration to moving to newborn screening for those?
So the question is, how are we doing with diagnosing young children who have a treatable form of epilepsy? And I think we're doing much better than we were 10 years ago. And a lot of these children are presenting in the NICU. I think we have made some efforts. You can apply for a rapid genome, and that can get you a result in 1 to 2 weeks. And I mentioned that there's an actionable panel in London that can take about 2 weeks, though you can ask for it to be prioritized. And yes, I probably could pass that question also to Pranish here about the incorporation of that into newborn screening on a research basis, because I think a lot of people are thinking about that, and it's a very important question. Yeah, you bet.
Yeah, thanks, Dave. I won't bite on that. In part because I just saw that Neil Sondheimer, who took my role with NSO, is going to be presenting.
Oh, great.
At some point, I'll try and find the date for people who are interested in that topic. Thanks for the question. Any other questions from the room or online? Sean.
Okay. What about testing for intron?
Oh, yeah.
Something
Yeah, that's a lot harder.
Repeat the
Oh,
question.
sorry. So Dr. Bogue was asking, what about those testing for intronic mutations or mutations that are outside of the exome? And we have sometimes access to whole genome sequencing, and that can be helpful to do that. But that's even today is getting harder and harder to have access to. So we certainly are finding people with intronic variants, but it's hard to get that genome sequencing. And I think we just sometimes you need to get it, have people come back in time and maybe look at research options and things like that. Any other questions?
Maybe I'll ask one question of my own. Hugh's gone now. But along the lines of what Hugh was asking, I often can think about or worry about the negative predictive value of genetic, genome, molecular-based testing, and if you're using the test to rule out the need for treatment, I find that's often a conversation I end up having. When the question is very specifically, could the individual have disease X that we can intervene with? So how often are you running into that, or how are you trying to evaluate that from the Ontario Epileptic, the
OAGTP.
OAGTP?
And
so, for example, are people ruling out pyridoxine dependency on that basis without doing a trial of pyridoxine or looking at the biomarkers that are more sensitive?
I'm certainly not aware of that. That's probably more Dr. McMillan in terms of the actual management. Certainly, when we talk about it in ECHO, we're always, it's run by pediatric neurologists, and they're often saying, no, for that example, do the trial. And if you think it's that condition, maybe do some of the treatments until you do the genetic testing and or have some sort of metabolic test that you do. So, yeah, I can't really answer that. That well.
And one follow-up question, not follow-up actually, a separate question. How extendable do you think this framework is to other areas where genetic testing may be really salient? So this has happened around epilepsy, it's great. What are the other areas where you think this could be actually generalized to help with?
Yeah, because it's kind of a Cadillac test a little bit. It's kind of a, we have the steering committee and we're taking pains to make sure we've got all the best genes, and takes up a lot of time. And there's only so many geneticists and neurologists in Ontario to do all this. I think it could be applicable to, say, to other indications. The big one, of course, would be maybe I think autism is the
maybe it's not the actual area, but how extendable is this model? Is this framework? Like, do you think it could be broadly applied, or is it so Cadillac?
I think
it's just we need Chevrolets.
Yeah, I think it's so Cadillac. I'll be honest, and I'm
trying to rage with our car choices.
yeah. And I think we probably have to have something more like a Chevrolet. Yeah, for other indications.
Okay, so we're ending right on time.
All right.
9:30. The presentation that I mentioned that Neil Sondheimer will present on newborn screening with genomic technologies, including these kinds of questions, is going to be on May 13th.
Okay.
For those who are interested.
I'm interested.
You're interested. Great. Okay. Okay. Thanks again. And I see Neil's on the call too.
Good.
So there you go.
Wonderful.
Thanks again, Dave, and thank you all.